Welcome to Life Support Learning Center, Pediatric Online Education. My name is Dusty Lynn. I'm the Pediatric Educator at the Life Support Learning Center. Today we're going to go over the Pediatric Emergency Assessment. In our previous presentation, we talked about the doorway assessment, the Pediatric Assessment Triangle, or the approaching assessment. And today we're going to continue on with the primary assessment. So our objectives, again, in review, we're going to develop a rapid, systematic approach when we walk into a room and see a child who's very sick, or a mom brings a child who's very sick. We're going to articulate that pediatric assessment triangle, and with that, it's going to direct us which way we go. So again, the emergency assessment, we'll review what it is, why it's important, what to do with it. Our phases of emergency assessment are that initial phase when you first see that patient. That's the pediatric assessment triangle or the approaching assessment. It involves the appearance, their work of breathing, and circulation. That is the first phase. The second phase is the hands-on, what you're actually doing at the bedside to assess this child. And of course, the third phase would be those ongoing assessments, reassessments, and the in-depth secondary assessment. So it is so important to have that systematic approach so that you'll know what to do in a crisis situation. It helps keep you focused and on track, even in an emotionally charged and chaotic environment, which often is the case in a pediatric arrest or pediatric severe critical situation. If you don't assess it, you can't treat it. So you need to assess it in the right order so you can treat in the right order. As a review, the pediatric assessment triangle or the approaching assessment involved the appearance, how the child looked, whether or not they were breathing, and what their circulation was as evidenced by their color. If you remember, we had two options based on that pediatric assessment triangle. And one was the ABC, hands-on assessment, and the other is the CAB, check a pulse, airway, breathing. So today we're going to talk about the primary hands-on assessment for those patients who are breathing, and that is the ABC. Airway, breathing, circulation. We'll talk a little bit about the disability as well as the environment. So our primary hands-on, if they're breathing, we want to assess ABC. And it's so important to remember that A stands for airway. Oftentimes people will say, okay, I'm going to start the ABC assessment, and they'll ask about bilateral breath sounds and totally skip over the airway. Very, very important to remember that any pediatric patient, and especially a baby, who happens to be lethargic has a threatened airway. So we should always address the airway, even if that is not the issue of why they are brought in. In this picture, I want you to notice how big that tongue is in this baby's head. And his oral pharynx, it takes up a lot of space. And normally it's not a problem. They keep their airway open, even when they're sleeping, on their back, wherever. However, if they're lethargic, not only are their muscles lethargic, but the muscles that hold that big tongue out of the airway are also lethargic. So it's very important to address the airway in all your ABC assessments and your ongoing assessments and the pediatric patient, because things can change. The first thing you want to know when you're assessing the airway, you're just basically trying to assess if it's patent or not. If you hear stridor, you consider that upper airway obstruction. Lots of different reasons why a pediatric patient could have stridor. It could be a partial foreign body. It could be an inflammatory process, or it could be congenital. And you have to rule out these things. There's a couple of things that before you even touch the patient, if you hear stridor, then you need to divert your assessment and call for immediate help in the situation where it's a partial foreign body. And you walk into the room and you hear this stridor, the first thing you need to do is look at the caretaker, the mother, whomever, and say, how long has this been going on? Because if she says, oh, he was fine, he was playing with his crib and I went to go answer the phone and I came back and now he's stridulous, he's got this stridor, Then, of course, you're thinking this is a sudden onset. It may well be a partial foreign body. And in his airway, if he's got a partial foreign body that's occluding his airway almost totally, and that's why you're hearing that stridor, if you pick him up or start to move him around and he takes a deep breath in, it could be a total occlusion. So in a partial foreign body, for the purposes of this situation, you're going to call for help. You're going to ask sometimes it's anesthesia, difficult airway, etc. But you're not going to jar the child. If he's moving enough air that you can hear it, you don't want to do anything to make it a total occlusion. So you're going to ask for help and get all the equipment and people in there. If you walk into a room and you see this child who looks very, very toxic, he has a high fever, he's sitting, leaning forward, and he's slobbering, he's drooling, he's not swallowing his secretions, and you ask Mom, how long has this been going on? And she says, you know, he wasn't feeling good yesterday, and this morning he woke up and he's got a high fever, and now he's watching you with his eyes, and he's looking at you like, don't touch me or I'll die, because that's how he feels. In this situation, it may well be epiglottitis. He has a high fever. It's a rapid onset, not necessarily a sudden. He could have been sick for a day, but his fever shoots up today, and he was not doing so well this morning, not feeling so great, and now he's in a critical airway situation. That is also somebody that you want to call difficult airway, anesthesia, whomever is the definitive treatment for a tenuous airway, and get them in there right away. If you hear stridor and you walk in and you ask Mom, how long has this been going on? Or she comes up to triage and she says, you know, he's had a cold for the last few days, and I heard him barking like a seal last night. He's got this low-grade temperature. That may well be croup. He's between 3 and 6 years old. That may well be croup. And then you're going to follow your protocols and such for that as well. It is good to know if this child has bronchial tracheal malacia, if he was an ex-preemie and he is coming in for whatever reason, or he's being admitted for whatever reason, and you know that he's an ex-preemie, and Mom says, yeah, he's got this thing, bronchial malacia, meaning he's got soft airways. That's very helpful to know in taking care of that patient in general, because if he gets really upset, his little soft airways could collapse and he could lose his airway. So knowing that in advance, pretty important as far as his history is concerned. The other thing, when we're doing our primary hands-on assessment, we're also now discovering what his true alertness is, or what his, again, response to his environment might be. Because our approaching assessment, or our pediatric assessment triangle, we might have seen him laying there and kind of notice his affect. But now we want to see how he's responding. Is he awake when we walk into the room? Do we have to say something? Do we have to touch him and elicit pain? Or is he unresponsive? That's also part of the hands-on A. Another way to assess that is the tickles. The overall appearance is what his tone is, his interaction. So again, you have to have some kind of interaction or observe his interaction with his mom. What's his consolability? We'll discuss in a little bit the inconsolable child. What's his look or gaze, and what's his speech or cry? So this child, as we're assessing him as primary airway alertness assessment, looks pretty good. He's watching you. He's got his eyes right on you. The point being, this is an ongoing assessment. This whole series that we're talking about, it's ongoing. Because if you walk in and now 20 minutes later you see this child is tiring out, and that's very concerning. Another concern for the pediatric patient, especially infants, if Mom says he's inconsolable, he won't quit crying. There's certain things that we might need to look for to see. Could be an infection. He could have a terrible diaper rash. You have to expose him. We'll get to that when we go to exposure as well. Babies with non-accidental trauma who maybe have a subdural. He's been shaken. That could also be a problem as why he's inconsolable. Is there cardiac disease? For example, SVT. In older kids, sometimes they'll say, we had this little boy who would say, oh, there's a mad fox in my chest that just woke up. I woke the mad fox. And that's how he would feel when his heart was racing for SVT. Well, you can imagine a baby can't say that, so he might just start crying and you can't calm him down. Certain reactions to medications, he could have reflux, all these different reasons why babies could be inconsolable. But an inconsolable child also needs to be investigated and to figure out why. So that's your airway and your alertness, primary hands-on. And now, again, this is our rapid cardiopulmonary assessment, our emergency assessment. So now we're going to go to B, breathing. And what do you want to do when you're assessing a child's breathing? The first thing you're doing, of course, is you're looking at his work of breathing. What is his breathing pattern? How hard is he working at breathing? What's his inspiratory versus expiratory time? And we're going to count his respiratory rate. And while we're doing that, a good 10 to 15 seconds, we're watching for a pattern. Is there an unusual pattern to his breathing? Then, of course, we're going to listen to bilateral breath sounds. We want to compare them. And again, it's an ongoing assessment with that as well. This is a great time to bring your end-tidals, your capnography, bring your SATs in. All of this in your emergency assessment for breathing. So you're asking yourself, is there respiratory distress? Is there an increased work of breathing? What are his bilateral breath sounds? What about his respiratory rate? Is it too fast or too slow? Do you hear noise like grunting? Just recognize that when he's grunting, he's trying to PEEP himself. He's trying to improve his oxygenation. Do you hear stridor? If you hear stridor, you're concerned about the upper airway. It's on inspiration. Do you hear wheeze? That usually is indicative of lower airway obstruction. Is he in respiratory failure? He's blue, it's not working. You go to listen, he's not ventilating well. And just recognize that any patient who is unresponsive and gasping, it's the same thing as if he were apneic and he is impending respiratory arrest. So this little baby, if you watch, you will see he's got head bobbing. He's working hard. When you're observing his breathing pattern, start at the top. Look at his nose. Do you see flaring? Look at his mouth. Is his mouth open and he's trying to take in more air? Look down on his chest. Do you see retractions? This child clearly has subcostal retractions. And again, his overall rhythm, you can see that he has head bobbing. That's very, very concerning for your respiratory assessment. So your breathing assessment in review, you're going to look for his work of breathing, looking for patterns. You want to count his respiratory rate, and you want to listen to bilateral breath sounds every time, every assessment, every reassessment. So now we're going to move on to circulation. Remember, our hands-on primary assessment for circulation, it's all about perfusion. Unlike adults where we just depend a lot on vital signs, this isn't just about vital signs, it's about our hands-on perfusion check. The best thing you can do is compare your pulses, central and distal pulses. Put your hands right on that patient. If you can get to femoral and post-tibial or pedal pulses, compare those. If you can't get that far that quick, then at least do your brachial and radial pulses. And by touching them, you're going to notice if he has a weak central pulse and a distal pulse that's not palpable. Oftentimes those kids are hypotensive. By touching them, you want to notice the line of demarcation of the skin temp. Is it warm? Is it cool? At what point does it turn cool? What is their capillary refill time? And recognize that the pediatric patient, it's important to do all of the above in different areas. If a child's in distributive shock, it might be very different. In one place, they could have a flash refill, a cap refill of like 1 second. Somewhere else, it might be very prolonged. And as you know, anything 3 seconds or over is abnormal. But also, a flash refill of 1 second really quick is also abnormal. And of course, in the circulatory assessment, after we do our hands-on, pulses, skin temp, cap refill, you want to count the apical heart rate and notice the heart sounds, your S1 and S2, and how easy it is or isn't to hear it. This slide depicts a capillary refill of 8 seconds in a little infant who was in cardiogenic shock. At the time the slide was taken, his blood pressure was normal, but he had an 8-second capillary refill. He was dead in less than an hour. You cannot go by blood pressure in a pediatric patient. You have to recognize they could be in severe shock and still have a normal blood pressure. So when babies or children are in shock, oftentimes they are poorly perfused and tachycardic. We categorize it by severity. Is it compensated? They're poorly perfused and tachycardic, but their blood pressure is still okay. That means basically that the body has reorganized its perfusion and taken blood flow from the less than vital organs and placed it into the core circulation. So it's shunted blood from the bowels and other areas and the skin maybe and put it to the heart and lungs and the brain. If by the time that child is hypotensive, none of the organs are getting perfused the way they should be. An irreversible shock is just that. That is cellular death that leads to organ death that ultimately leads to the child's death. So it's important to recognize a patient in shock before they get hypotensive because it's a rapid spiral. Once we recognize the severity of shock, we rapidly determine what the cause or etiology it is from and the type of shock that it is. We will do further presentations on pediatric shock where we go into each one of these, but for now we're going to just stick with the assessment. So D stands for disability. That's that ongoing investigation of the neurologic status of this patient and everything that affects it. And of course, you know, altered mental status or a patient who is lethargic, you want to check a glucose right away and make sure that that is okay. And we also check pupils, our glaucoma, and it's that ongoing level of consciousness assessment that we're doing. And don't forget that infants also have fontanelles that you want to check your especially anterior fontanelle. Glucose checks should be ongoing. One glucose check in a pediatric patient really doesn't mean anything even if it's stable. You know, if this is a sudden event and the liver releases glycogen stores because, oh, this is a trauma and there's a problem, and you check a glucose 20-30 minutes later, it might be normal. But because of their high metabolic rate, it could be tanked in no time. So you really want to continue to check probably about every 30 minutes until proven stable in the pediatric patient. Here's some pictures of fontanelles on infants. You can see the two on the left look pretty sunken. The two on the right look like they're bulging. And so, again, that's an ongoing assessment for your infant fontanelles. Now we're going to briefly talk about exposure as well as temperature. And here's where we're really looking for the unobvious. The things that are going to kill a pediatric patient the quickest are your ABCs. We recognize that, but it's very important to continue on and do your disability and your exposure as well. So here are some things that we were talking about earlier when we were talking about inconsolability. You can see the toes in the picture here are all hair tourniquets, as well as the penis. These are all situations where a piece of hair got wrapped around a digit and cut off the blood flow. You may not even see it. It may just look like a wrinkle in their skin, and yet it's very, very painful initially until it goes numb and they've lost function or actually could lose that digit. A punctate wound as well. The slide on the right you see is a child who clearly was in a trauma, and you see road rash, and you have to think, okay, what is underlying in there? And of course, they could have multi-trauma. To decap BTLS is something that we talk about in EMS, as well as just a great mnemonic for things that we're looking for when we're doing a thorough hands-on head to toe. We're looking for deformities, contusions, abrasions, punctures, penetrations. You're looking for burns. Is there areas that are tender? You're looking for lacerations and swelling. And of course, now's a great time, if not before, in various pieces that you want to get a history. And you want to get a full sampler history. The signs and symptoms that you notice that they're complaining of. Do they have any allergies to food, to environment, to medicines? Are they on any kind of medications? The other thing to ask when you're asking about medications is, especially if this is a toddler or this is a teenager and they present for changes of level of consciousness and you don't know why, think toddlers and teens for toxins. So when you're asking about medications, it's not just in the immediate environment. You want to ask about the last 24 hours. Could this toddler have gotten into any kind of medication? Because if mom was at Granny's house last night and little Johnny was crawling on the floor and you ask, is there anyone in the house on medication? She may think you're talking about her immediate home, and she would say, no one here is on any kind of medication, when in reality grandma may be on sustained release verapamil that little Johnny ingested last night and he didn't become symptomatic till this morning. So good to ask 24 hours or so. What is the past medical history? We talked about some things that are very significant. Again, ex-preemies, you think about airway issues. When's the last time they ate and what it was, intake and output, how many diapers they've wet, those kind of things. Events that led up to the situation is also very important, and risk factors. And we'll unpack this just a little bit, just because there's certain things that you may need to ask that otherwise the sample history may not pick up. If you have a teenage girl who comes in respiratory distress and you can't figure out why and nothing comes up on the sample history, you may need to ask very specific, are you on birth control? Because she may not consider that a medication, especially if it's an insert. She might not at all consider that as a medication. If you ask, is there smoking, and she's actually vaping, you might need to ask very specific about tobacco products. So those kind of things that would come up under risk factors and not necessarily under the sample history if you don't ask the R. So again, in summary, you have to develop a rapid, systematic approach to the pediatric patient who is in extremis. You need to, as you're approaching him, have that approaching assessment, that pediatric assessment triangle, which is going to tell you what your primary hands-on assessment is going to be. Is this an ABC assessment or is this a CAB assessment? And you go down that pathway with your rapid reassessments as well. Practice on well children. Every single child that comes into our purview, we should be doing a rapid cardiopulmonary assessment. And though we won't talk about it in this presentation, we will in subsequent about non-accidental trauma. And it is important to be assessing for that for every single patient, regardless of why they come in. 70% of the patients who come in with non-accidental trauma with devastating neuro damage or death have been seen in the recent past for something else, gastritis, otitis, other things, and we've missed it. So we have got to be looking for signs and symptoms of pediatric non-accidental trauma in all of our patients. So thank you for joining us for our online education. We hope that you'll join us for our classroom experience as well. We go over much more detail, and we have an opportunity and time to do case discussions, etc. So please reach out if you have any questions, any suggestions for other online education. I'd love to hear from you. Thank you so much.
Hi, I'm Dusty Lynn from the Life Support Learning Center, and today we're going to go over the brief overview of the Pediatric Emergency Assessment. We discussed in a previous presentation the Pediatric Assessment Triangle. With that, we determine are we going to go down the ABC pathway or the CAB pathway. So today we're going to go down the ABC pathway, meaning in the Pediatric Assessment Triangle, the patient was breathing. So the first part of the primary hands-on assessment, A, stands for airway, airway and alertness. So when you're addressing the airway of the pediatric patient, always assess it, because even if they're not here for an airway issue, for any reason, if this patient is lethargic, it's so easy for them to lose their airway. If you notice, just by laying flat on his back, if he becomes lethargic, he loses his airway. So we always need to make sure we address the airway. Sometimes a simple blanket, sometimes a neck roll from something else, but you want to lift the chin off the chest, ensuring that it stays patent. As such, The other thing that you are assessing when you are assessing the airway is any sounds that he might be making that's related to an airway issue. Is there upper airway noise? Stridor on inspiration is usually indicative of upper airway. In our PowerPoint presentation, we talked about some issues that would preclude you to doing anything else if you hear certain airway noises. So I refer to that as far as continuing on now for our airway. And now we're going to discuss his alertness, all under A. So this is where we're actually eliciting his response. So the pediatric assessment triangle will tell us kind of how he's laying there and what his affect is. But now we want to see his response to stimulation if it's not obvious. If he looks like he's sleeping and we come up and we make some noise, does he wake up? Is he awake? Is he awake to voice or noise? Does he not wake up to noise and we have to elicit pain to see, is he going to respond? If he doesn't respond to that, is he unresponsive totally to anything that we're doing? So again, the AVPU. Some people will use the tickles as well to assess for his responsiveness to his environment. And again, this is an ongoing assessment throughout your patient contact. So now that we've discussed his airway and his alertness, let's go over B, breathing. And again, this is a rapid cardiopulmonary assessment. This isn't the end-all ICU admission assessment. This is just you walk in a room, this patient is very sick, and you're trying to get to what the problem is. So B for breathing. The three things that you want to assess are his work of breathing, his respiratory rate, and his bilateral breath sounds. So to notice his work of breathing, you have to be able to look at his complete chest. If you leave him covered, you might see from here up, you might see nasal flaring and think it's not that bad. And then once you expose him, you realize he's really working hard. So always undress your patient so you can see. Look at the top of the airway. Do you notice any flaring? Look at his mouth. Is he gasping? Look down his chest, at his sternum, his ribs, beneath his sternum, and his rib cage. Are there any retractions? So what's his work of breathing? Then you want to assess what his respiratory rate is. And for this, you really want to count at least 10, if not 15 seconds. Because not only do you want to get a respiratory rate, you want to also look for any kind of patterns. Some babies who have neurotrauma may have a very rapid tachypnic type of pattern and then this little pause. And you'll miss that if you're not watching for it. So again, your pattern of breathing and your respiratory rate. And finally, you want to listen to bilateral breath sounds. And a quick down and dirty for the pediatric patient is his bilateral mid-axillary, furthest from his lung fields assessment. If you just assess in the pediatric patient his breath sounds here and here, they are going to resonate and you're going to miss what's really happening because this might sound like what's really going on over here. So again, you want to listen everywhere, but at minimal for a rapid cardiopulmonary assessment, you want to listen to mid-axillary bilateral breath sounds. And that's your breathing assessment. Work of breathing, respiratory rate, and bilateral breath sounds. So continuing on with D, disability. This is where we're going to assess his neurologic status. And remember, on infants, they have fontanelles. So you can assess their anterior fontanelle. Again, it's kind of a sideway assessment. You're certainly not pressing on it downward, but you want to see, is it level to the skin? Is it bulging? Does he have increased intracranial pressure? Is it sunken? Is he extremely dry? So fontanelles. And of course you want to assess pupils as well. Are they equal? Are they equally reactive? Are they round? Assessing your pupils. And glucose. We want to do a glucose check as well. And as we said in our PowerPoint presentation, we talked about the importance of when you check a glucose on a pediatric patient, if this is a sudden event like a trauma or sudden escalation of a critical situation, when you check a glucose, you really need to continue to check them until proven stable. because as you know, if this is a sudden event and you're checking a glucose, that liver lets go of all those glycogen stores, converts it into glucose, you test it, and it might be normal, might be even slightly elevated, and you're like, oh, it's fine. His metabolic rate is so fast that in a half hour it could be tanking. So you want to check a glucose on a critical patient until proven stable, probably about every 30 minutes. And so that's your D, disability. And ongoing with that, of course, it's all interrelated, because your cardiac output, which is what we were talking about in their circulation, is also indicative of their level of consciousness. So if that starts to change, one of the first things, of course, that you think about is he has decreased perfusion to his brain. So again, D, disability, you're checking fontanelles, you are checking pupils, and you're checking glucose. And again, just in general, level of consciousness. And that's your primary hands-on for D, disability. So for the final component of the hands-on ABC, Pediatric Emergency Assessment, we're going to talk about E, exposure. This is when we're looking at his skin from head to toe, and we're looking for any rashes, any burns. We are palpating for any tenderness. And just recognize that nationally, 70% of the kids who come in with non-accidental trauma have been seen in the healthcare system in the recent past for something else seemingly unrelated to non-accidental trauma. Gastritis, otitis, accidental trauma like a broken arm or something from running and falling. And they're coming through our system and we're missing them. So every single pediatric patient who comes through our purview, we should be looking for signs of non-accidental trauma. Every single patient. So exposure, we're looking for all the signs of any kind of broken bones. You might see a finger that is malformed and you're thinking, gosh, that's kind of weird. It could have been broken and not sought for treatment, and it healed that way. You're looking for bruises. Certainly anything on the back, any bruising on the back is very suspicious. And remember, if this is a small infant, if they don't cruise, they don't bruise. So any bruising on an infant who is not mobile should be investigated. So we just have to it cuts across all socioeconomic groups. We just have to look at every single pediatric patient and look for signs of non-accidental trauma. The other thing that we're going to be doing is, of course, taking his temperature as well and seeing what that is. So again, this is the hands-on rapid cardiopulmonary assessment of the pediatric patient. You certainly want to do your ongoing assessments and your secondary assessment, your history, your sampler history as well, and continue to maintain diligence in assessing your patients while they're in your care. Again, this is Dusty Lynn from the Life Support Learning Center, and thank you for being with us today.